Well, we are so honored today to have Dr. Donna Reece join us. Originally, she's from Texas, and Dr. Reece attended medical school at Baylor College in Houston. She completed residencies in internal medicine and fellowships in hematology at St. Louis, Missouri, and in Colorado. She then practiced hematology for 10 years in Vancouver. Afterwards, she was the director of the blood and bone marrow transplant program in Kentucky. Most fortunately for us here in Canada, she joined the Princess Margaret myeloma team in 2001 and has been the director of the program for myeloma and related diseases at Princess Margaret for most of the time since then. And since 2009, Dr. Reece was the chair, as I mentioned, of the Molly and David Bloom Chair for Multiple Myeloma Research. And the funds are raised from patients, their families, and friends in the annual walk that I mentioned. And this has helped Princess Margaret to become one of the leading myeloma research centers in the world. And this is not an exaggeration. Dr. Reece serves on the Myeloma Canada Board of Directors and led the development of the Canadian Myeloma Research Group, which has become an increasingly successful research organization, bringing leading myeloma research from across Canada together to collaborate. For many years, she has been the chief medical officer of the CMRG, as it's known, which I believe she does as a volunteer. Dr. Reece is a world-renowned myeloma researcher. Most importantly for us, Dr. Reece is known for her profound dedication to patients, attention to patient care, and kindness. She is also, in many ways, a very strong advocate for patient needs. So with that in mind, Dr. Reece has a huge amount on her plate, all working for us, but for taking the time to prepare her presentation today and to speak to us today. Would you please all join me in giving Dr. Reece a most warm welcome? Please clap. I think she can see you.
Thank you.
Dr. Reece, thank you again so much.
Thank you. I was going to remind you at the beginning to please keep it short, which you did not do. But thank you. The privilege is mine to speak to this group because the folks on this call are the ones for whom we exist. I think we are very fortunate in Canada to have such a strong grassroots organization, such as Myeloma Canada, that really can serve as a model for other groups of individuals with a common disease. And it's been my privilege to be involved with Myeloma Canada, oh my gosh, probably 15, 16 years. And indeed, it is a privilege. It's been a long time since I've spoken to a support group, mainly due to obvious factors such as COVID and the fact I wear 3 hats. I see myeloma patients. I run the clinical trials group at Princess Margaret. And as David said, I have to laugh because I'm not a business person, but I'm the chief medical officer of CMRG. So I think the topic David suggested was news in multiple myeloma research. And whenever anyone gives a talk on myeloma, I mean, sitting down and just trying to decide the breadth is a big task, because you can make a whole hour presentation out of treating. What do we treat? Newly diagnosed patients who are destined for a stem cell transplant. How are you going to treat those that are not going to have a transplant? How do we treat first relapse versus further relapse? And then what's new further down the treatment sequencing, because patients live a long time. We rely on sequential treatments to get all we can in terms of control of the disease, good quality of life, as long as possible with each line of therapy. And obviously the newer treatments are evaluated first in the very advanced disease setting and then moved up. So we continually have shifting sands of the trials. One can spend a whole talk on new laboratory tests that we are integrating into the clinic. And I actually had to take that out of this talk because even though you all are a wonderful audience, I think you probably want dinner tonight. So that may need to be the subject of another presentation. But be it as it may, progress in myeloma has exploded, which is excellent. And I think our role is to bring new drugs to Canadian individuals with myeloma as quickly as possible. And I see that as our main mission at CMRG, getting new drugs to our patients. So I'm going to take the approach of starting out what are our current treatment approaches today in myeloma, and highlight some of the benchmarking results from our national database that told us where we are, and offers suggestions for where there are gaps, where we really need to work with high priority to improve the result of a certain line or population of patients. And then to highlight in here some of the selected results from ASH 2021, because myeloma, I'm heard, was, I can't even remember the percentage, well over 20% of all the hematology presentations at ASH. And, you know, that includes lymphoma, leukemia, thrombosis, benign anemias, et cetera. But what is really important and what is our mission as clinicians is what are we doing to improve the outcome of our patients? And I won't have time to go into detail, but I'll try to highlight what are the relevant clinical trials, which remain a very important but still relatively limited pathway to get access to drugs. We do have special access and compassionate programs. Special access comes through Health Canada. Compassionate comes from the drug companies specifically. And then I won't have time to go into detail, but there is a dedicated group of Canadian hematologists that are really pushing on CADA, and have for a couple of years, when they come back and say things like, well, an individual can only have access to pomalidomide or carfilzomib, but not both. The answer steadily has been, no, 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 we will not sign off on this. You know, and they've revamped the input process, and we will continue to advocate for drug access and counteract this idea that because myeloma has so many new drugs, well, you know, we have to take away something when something else comes, but that in a sense is penalizing progress. You know, that doesn't make sense. And I think myeloma for a blood malignancy has led the pack in new drugs. And if we start doing that, what's going to happen with other treatments for lymphoma and such as they come out in the future? So I think this is a very bad precedent, but it is, it's a relatively new one. And then one of the real challenges I think you're all aware of is drugs are priced not on the cost of research and development, because obviously the trials are horrendously expensive for pharma, but they're priced on innovation. Well, what's that? It's expensive. So I will just add, we are fortunate in several respects that I'll try to highlight that all is not negative in Canada. And as you've heard, I practiced on both sides of the 49th parallel. I would never go back and practice in the US. It seems like it's a wonderland, but there are many, many problems in a system that is based on giving as much drugs over as long infusion times, as long as possible, because it's a completely for-profit system as opposed to a socialized system. So I think it's important to counteract that we have to push, but we're not in terms of dynamics in such a deprived state. And I've evolved to thinking that there are pros and cons for our Canadian system. And I would also preface this whole discussion with that. So obviously treatment, the landscape is evolving at warp speed. And the bar for funding a new regimen is high. It's typically been a good phase 3 trial with lots of follow-up, preferably survival data. Well, our patients survive years. And by the time the trial results are out, the prior treatments have changed. And we know the provincial funding pot is not infinite. And this results in public funding for drugs being inflexible and slow. And what we've seen arise in several provinces is a two-tiered system where if you have drug insurance, you can get the Health Canada drugs before it's public. And having happily left an insurance-based system, this makes me sad, but you have to get the right drugs to as many people as possible. There aren't easy access for unusual or exceptional cases. And once a treatment is approved or, doses are locked in per province, it can be challenging to go back and adjust based on our experience, even if we have database results. And really, there's no good quality data on the best sequencing of all the different regimens we have. However, we do have some real advantages. Now, theoretically, every patient can receive an acceptable standard of care. And the myeloma medical community does require or depend on evidence to treat patients. That, we're not putting together drugs just because we think they work. We're not profit driven, which is an important key. I've just had candidates that are interviewing for a new position at Princess Margaret who've been practicing in New York saying that in their center, the docs give twice weekly IV bortezomib, Velcade. Why? It is much more money into the system than giving it weekly sub-Q. You don't get income prescribing oral drugs or subcutaneous drugs in the US system. And don't underestimate how that drives a system that depends on a practice making money to pay their nurses and their staff. That's how they stay in business. Canada is very interested in oral and subcutaneous and less frequent dosing. That helps our patients. And because we tend to practice similarly across the country, in large part driven by our funding, we can really look at our results without the vast heterogeneity that is seen in the US. And that has helped us do benchmarking and see how we're doing with what we have. So I spent more time on that than I meant, but I think it's an important perspective. And I hope provides reassurance that we have to push, but we have a system that is trying to meet the needs of all cancer patients. So I'm going to start with at the beginning. This is our current treatment algorithm. And I'm going to start with the transplant eligible population because these are the patients we see most at Princess Margaret. We tend to see those who are transplant eligible because we do over 200 autografts a year for myeloma. Non-transplant therapies are often done more in the community. Our other big group is clinical trials. And then I'll talk about transplant ineligible, first relapse, which is very important, a bit about second relapse, and then some of all the new goodies that you've been hearing about at ASH. Okay, so this is a bit older data, but it really lets us know where we've been in Canada over the last almost 8 years or so. So what we have access to is good old Cyborg-D given orally for cyclo and subcutaneously weekly for bortezomib. And then a single or double transplant, depending on risk factors. And we have been a country that's one of a very few, last count, it was 7 or 8 countries that had public funding for lenalidomide maintenance. And that has elevated the results no matter what we give at the beginning. It's like the great equalizer after the transplant. We do use alternatives in selected patients, but I think the bottom line, this is a really informative analysis in over 1,200 patients that had mostly, well, they all had bortezomib or Velcade-based induction, usually Cyborg-D. These were without maintenance. This is the progression-free survival. This is with maintenance. So our median progression-free survival was about 5 years. And I'm always careful to say we deal with medians, does not tell one patient what their outcome is. It means half of people go longer and half of people will have the disease recur earlier. So without maintenance, a little under 3 years median, with maintenance, about 5 years. But the survival in each group was not reached. Now, high-risk patients are always a challenge, and we are developing better ways to segment these people. I don't have time to talk about it. I had to take that part out. But you may be aware that we use FISH cytogenetics to try to decide who are the 15% of people whose disease is going to come back earlier. And what do we do about that? Now, this shows what we were doing many years ago. We had a regimen, I hope no one remembers, called VAD. The V was vincristine. It was massive doses of dexamethasone, no maintenance, and the progression-free survival was abysmal. It was barely a year. You don't want to do a transplant for a year. Now, doing tandem transplants, tandem with maintenance, single with maintenance, this has improved dramatically. But we know, and some of you in the audience may be aware, that your physician can say, oh, I'm worried you have a certain translocation, 414, 17p deletion, but people live years and years and years. It's not high risk. So we see where we may have alarmed people trying to give them the best data we have. We now have the tools with a molecular test of bone marrow to sort out. It's only 25% of patients with 414 or 17p deletion that are really high risk. The others are standard risk. So until we can segment these, we can't target the best treatment to the best patient. I'm very happy that we finally have this 38 gene panel that was developed by Trevor Pugh and Suzanne Trudell in our center in the clinical lab, and we can order it. And we are using philanthropy, donated funds to pay for the test. So we can really start to learn who's high risk, who isn't. You can tell this drives me crazy because not only do we owe it to our patients to really try to give them an idea of, is this going to be, we think, a well-behaved myeloma that will go years, or is it one that's a more aggressive weed that we need to treat differently? Now, there's a great deal of discussion about, oh, we have not had RVD before stem cell transplant. And I push for every combination we can get, but I want to provide some reassurance. I've just shown you our results, good old Cyborg-D transplant, maintenance until progression, where we got almost 5 years, has compared very favorably to the standard, which was the French IFM trial of RVD induction, transplant, RVD consolidation, and len maintenance. Now, they only gave the maintenance for a year, but in a real-world population, we got 58 months. In their study population, where patients were selected for good kidney function, good blood counts. With this trial, they got 50 months. So, we were not doing too badly. So I'm not saying we rest on our laurels, but I think we have to really look at the data. Are we suffering? And again, it's the lenalidomide maintenance that has mopped up and helped patients live longer. I will also say in Canada, we use lower doses than the trials in the US, because if you give daily higher end doses of Len, there's side effects. And again, the goal is control the disease as long as possible with good quality of life. And we have good data from Princess Margaret that you don't have to give the highest dose. Interestingly, that manuscript has been reviewed and declined in several journals because it doesn't fit the algorithm. Chloe Yang, who's joined our group, had a presentation at ASH in a poster several years ago. But it's very reassuring that you may not have to make patients sick to help suppress the disease. Len and POM and thalidomide work two ways. They kill myeloma cells, but they also enhance the immune system. And a suspicion many of us have is that the low doses augment the immune system. And we don't have to go to the higher doses that poison the myeloma cells directly. Anyway, I digress. I'll never get through this talk if I don't move on, but hopefully this is relevant information. If it's not, put your hands up and I'll go faster. Now, that said, there is an arm of this study here that Len was given until progression. And we think that outcome is going to be presented at ASH this year. And it may very well go much beyond the 50 months of the 1 year maintenance. And again, we don't rest on our laurels. We need to do better. And I think the most important effort right now for our transplant eligible patients is to integrate immune therapy into first line treatment. Now, what that means realistically is add one of these anti-CD38 antibodies, either daratumumab or isatuximab, Darzalex or Sarclisa, to some component of induction consolidation. You can tell I like the maintenance. There are trials I'll describe that add newer immune agents. And then there's this whole field of using marrow MRD with to determine whether patients can stop treatment or continue treatment. This is a very complicated topic. MRD, in my mind, is a deeper complete remission. Deeper responses are always better than less deep responses, but keep in mind that myeloma is very heterogeneous. My longest surviving patients after a stem cell transplant that are 20 plus years have never had a CR. So do those patients need to be MRD negative? So I think we have to be smart and learn who needs what, because do we have to give huge amounts long therapy to someone who's going to do very well with a little bit of M spike for 20 years? So anyway, these are perplexing questions that I think need to be taken into account, and they're ones that we want to help with our CMRG orientation, which again is not to pound everyone with as many drugs as possible for as long as possible. So now, getting to more of the punchline, how can we in Canada integrate DARA or EASE into frontline treatment as soon as possible? I've just shown a schematic here. These antibodies are made in the lab, and I have a slide later on because I think it's so paradoxic that myeloma is a disease of the cells that make antibodies, but we can harness antibodies in the lab and educate them to attack a certain marker on a cancer cell or myeloma cell. And that these are called naked therapeutic antibodies. And these that I just talked about stick on this surface marker of the myeloma cell, and they wave a flag, if you will, to the other portions of our immune system and say, hey, come kill me. Now, the problem obviously is Health Canada and CADIF requires phase 3 trials, preferably survival data, before they approve a drug. That's going to take a while for the ongoing studies, because already for transplant patients, the median PFS is 5 years. It's going to be quite a bit longer. Well, patients are waiting. So what clinical trials do we have? Now, this is a very busy slide, but tries to provide you with an update of 3 of the most important trials presented at ASH that gave a new antibody, either ISA or DARA, along either with VRD, Velcade, Revlimid Dex, or Carfilzomib Revlimid Dex with an antibody. And after the transplant, gave Lin and DARA, Lin and ISA. Some allowed continuation of Lin alone afterwards. And what you can see, we have data so far that goes out 2 or 3 years. The complete remission rate is very high. This is an early trial. So this is an overall response rate. This is at least complete remission. You can look at MRD, which we hope will be a surrogate that the funders will look at, because usually the more deeper CR you have, it correlates with a large group of patients with how long the benefit is. And then at 2 or 3 years, really almost 90% of patients are still in remission. So these are new benchmarks. We don't know how long to give the maintenance, particularly in high-risk patients. I don't have time to go into the master trial, but those patients who had KRD, transplant, and then had KRD and MRD monitored, and if they had 2 MRDs, you stopped all the treatment, continuing Lin maintenance, only if they were still MRD positive. But for the very high-risk patients, within a year of stopping, despite prolonged MRD negativity, a quarter had already relapsed. So high-risk disease, I'm very cautious about stopping treatment, because until now, all the studies have showed, in general, the longer you suppress the disease, the better. Now, of course, there's side effects. That's always the balance. So getting to the punchline, what are we trying to get into Canada to help our newly diagnosed patients? We have a trial, a CMRG trial with 10 sites that takes our backbone. We have a great historical control, that 58 months, and we just have isatuximab added with Cybor-D, and isatuximab and lenalidomide until disease progression. And this trial is accruing very fast. Everyone gets the isatuximab. We finally got funding through philanthropy at Princess Margaret to do MRD, because when you do these investigator-initiated trials, pharma doesn't give you much money, but we will be able to do MRD, thank goodness. There's another trial in several centers that offers DARA subcutaneous and lenalidomide to half of patients. It's a randomized trial, but it will offer DARA subcu to some patients. And patients start this after transplant. So for those patients that we can't get on this at diagnosis, we can offer them a trial after transplant that may get daratumumab into maintenance. Now, we have 2 other trials. Importantly, CCTG, which has an advantage in that it has its ability to offer treatment in smaller centers. Myeloma, there were many CCTG trials for myeloma in the past with thalidomide, melphalan, this trial can offer post-transplant Lin versus Lin-DARA, and there's further randomizations to de-escalate the treatment in MRD negative patients. And this trial is is getting started soon. Unfortunately, these trials pay very little per patient. I mean, we're talking in dollars and cents, $3,000 to $4,000 to cover all the research nurses, the data coordinators for a trial that is going to run 10 years because it's based on survival outcomes. And when you have so many people doing the trial and giving the drugs, where is this money coming from? Which is a disadvantage from these trials. Another trial that we are, of course, sort of a clearinghouse at CMRG is we've been invited to partner with another group in Europe, which is very active, called the EMN, and it will integrate a bite for maintenance after stem cell transplant. Now, I'll talk about bites later, but this again starts after transplant and randomizes patients to lenalidomide alone or lenalidomide with this bite that some of you have probably heard of, teclistamab. Again, it's only half of patients. I like trials where everyone gets the goodie. But right now, these 4 trials are, and we're aggressively looking for others to improve the outcome of our transplant eligible patients. Now, I'm going to say a little bit about antibody and CAR T treatment, just because some of the other parts of the talk about these treatments that are being moved further and further up front. I believe you had a talk about bites and CAR T cells from one of our wonderful fellows who will be joining the staff in Ottawa later this summer. It is a wonderful contribution. We have a whole generation of younger myeloma docs in many centers. So centers of excellence are being built in a number of centers across Canada, which is really, really cool. Not everyone needs or should come to Toronto. So I think elevating the national research capabilities in Canada is an extremely important goal. But you probably are aware a myeloma cell, and they've shown it schematically, has a bunch of surface markers or antigens that help identify it as a myeloma cell versus a skin cell. And you can make antibodies to these markers that, like the naked antibody I showed before, sticks on it. So the ESA and DARA recognize CD38. Elotuximab, which we've only had in trials and isn't marketed here, recognizes SLAMF7. Where there's a tremendous amount of effort is against this marker BCMA. And what's important about the markers identified, because there's tons more, is that they're largely only on myeloma cells. You don't want your antibody sticking on heart cells and calling in the immune system to attack it. So you want an antibody that's by and large restricted to the tumor cell. The other ones that are coming up, and we have a bite against, is the GPRC5D, and there's one other that isn't on here. But to give you an idea of, first we had to find these targets and then make the antibodies against it. And I thought it might be interesting to talk about, as I said, I've always been fascinated that in myeloma, the problem is these plasma cells that normally make all kinds of antibody every time our body is challenged by an invading antigen, like COVID. You know, we get vaccinated, our good plasma cells make an antibody to make us immune to COVID. Myeloma, one of these guys gets immortalized, with time can become more cancerous and makes the same antibody. Usually that antibody doesn't do anything. We don't know what it fights, but it's a tumor marker. We measure it to know how much disease is in the marrow, because the only other way, and it's imperfect to measure the tumor burden, is to do a PET CT. And even that will miss where the myeloma is in some cases or when the burden is low. Now, what is the whole era of monoclonal antibodies made in the lab is quite old technology, but they inject an animal with an antigen, let's say CD38, and then they take spleen cells that can make antibodies and mix them with cell cultures of myeloma cells. And they mix them together, they fuse, and you get cancer cells that make the antibodies against this antigen. And then they pick out which antibody forming cells make the best antibody against the marker. They look at how well does it stick to the antigen like CD38, how long will it stick, et cetera, et cetera. And then they can choose this and turn this into a factory and make tons of antibodies against one target. And they can make these humanized so our body doesn't react against them, which is really, really cool. And we have humanized monoclonal antibodies for lymphoma, breast cancer, and now myeloma. Now, the next step is to make these antibodies more effective. And one way you can do that is by adding a warhead, a poison to it. And this is what we call antibody drug conjugates. So the antibody sticks on the marker on the cell surface of myeloma cells, and it delivers a toxin to those myeloma cells. And that's what belamaf is the prototype for. It's approved in the US. And we certainly have treated many patients on clinical trials. The bites are more specific, and they are interesting because they take this Y, which usually in antibody therapy, this would stick on CD38 or BCMA. This will stick on BCMA or CD38. It's the same, it sticks on the same target on the myeloma cells. What has been done is engineer these so they recognize different things. This recognizes CD38, but this recognizes a killer T cell. So that brings the cancer cell right next to the killer cell that's already circulating in the patient's body. So we now have and the abbreviation is BiTEs, bispecific T cell engager antibodies. So we now have these, I've already mentioned teclistamab. And what's really cool is we have them now in clinical trials in Canada that recognize different antigens. And we're seeing that a patient who may have one and it quits working or doesn't work, well, you can target another antigen and another antigen. And now we're learning, we may be able, if one against BCMA doesn't work, maybe another one doesn't. And then, of course, T cell, CAR T cells, you actually put the tumor binding antibody on the killer T cell directly and infuse the whole cell, not just the antibody. So hopefully that's a bit of a reminder of what this new era is in myeloma treatment. And I think it is a bit confusing, but these are really marvels of biologic engineering. So back to reality. I've talked about transplant eligible patients. What about the very common situation of someone that's over 72 or so at diagnosis, or isn't a good candidate for transplant? And our previous options, this was really our first CMRG database in 750 patients. And this is our median progression-free survival for CyBorD and VMP, which are generally given for 9 months. That's all the funding. We don't use a much Velcade Dex alone. If someone's frail, that has been used in the past. And then one of our first advances was just to give Revlimid and Dex. And the importance of this study was to show that weekly VMP and CyBorD gives exactly in other reports of twice weekly with much less peripheral neuropathy showed that CyBorD and VMP give identical results, because cyclo is much easier on the bone marrow than melphalan, and is easier to give in kidney failure. And the other point was these outcomes are identical to what was shown in the phase 3 trials. So we showed in the real world, and so you don't exclude patients on dialysis, you don't exclude patients with low blood counts. This is who we treated. But this isn't good enough. So more recently, VRD or RVD has been funded. We are still giving weekly bortezomib, and we are in the process. It's just been funded a year or two. We will look at our outcomes in our database, but we still have much work to do for this group. Now, you've probably heard when you line up a bunch of trials and look at the results, that is supposed to be a big no-no, because what if all the patients in this trial had high-risk chromosomes and these didn't? It's not kosher to do that. On the other hand, what else do we have to guide our treatment in patients? But I've already shown you, this is in the phase 3 or other trials. We were getting exactly what was seen, which was very reassuring, and hopefully was reassuring to our funders that they were getting their money's worth. But the world has moved on. The RVD with weekly bortezomib, which you can give much longer without peripheral neuropathy, versus RVD in the SWOG trial. These are in older individuals, not the whole group. You can see you get about a year and a half here, 2 years here, 3.5 years with RVD. But what is really the relative home run is daratumumab RD, the so-called Maya trial. Adding Dara to VMP or CyBorD is helpful and avoids some of the toxicity of RVD, but really it's this one that is making a huge difference, and we've been waiting patiently and agitating aggressively to get this funded. Now, the fact that Revlimid is now generic has helped, because the cost per quality life year saved with this regimen is horrendous, well over $1 million per patient. And given that this will be probably the preferred therapy for everyone who isn't going to have a transplant, the usual value that CADITH has looked at, cost per quality life year saved, is $100,000, and now they're trying to make it $50,000, which is, as an aside, ridiculous. But what we're seeing with Dara RD is an amazing median progression-free survival that's not quite reached at 5 years. So this is very close to what we're seeing with our previous transplant outcomes. I will add, this is a very good regimen to give, but as we move into the immune era, we have to realize that suppressing the immune system is part and parcel of suppressing the myeloma cells and antibody levels, because plasma cells are part of the immune system. So we've learned that regimens with Dara and ISA up front or later on, you really need to be attentive to infection. And we're trying to educate the community docs, as we have learned that you really need to prevent shingles. You need to prevent 3 times a week PJ pneumocystis pneumonia, which was not appreciated when these drugs were first used and was not mandated in the clinical trials. Bacterial infections are more common. I think we've learned that now, and we're conveying it to community docs. And I think the other point, and some of you may have experienced this, for many years, we relied on making decisions on how far to evaluate patients, whether to give them IV or oral antibiotics. Did they have a fever, and did they have a low neutrophil count? Well, with these other immune treatments, we have found that patients may not have fever. They may not be coughing. They may not be neutropenic. They may just feel terrible. And we've learned that if patients come into clinic on these drugs and tell us that they feel horrible, we go directly and do a low-dose chest CT scan. We don't even bother with a chest x-ray. It's not sensitive enough. And we look at the O2 sat, and we often find an early pneumonia. So we're educating emergency room docs, to be mindful. This is a solvable problem. It's just a shift in seeing what these drugs do. Another exciting aspect is DARA. Subcutaneous administration is much easier, even over the 90-minute infusion, which we did as a CMRG trial and established the safety of that. And it's been approved by Health Canada, and we think it's going to be funded soon, which is a huge quality of life factor. Isatuximab, we will be doing trials. It's a bit behind in subcutaneous administration. So what do we have for our patients who are transplant and eligible? We do have a CMRG trial that is like RVD light, but we use a new improved lenalidomide or Revlimid. This compound is even better against myeloma than pomalidomide. So this trial, in large part due to Celgene being purchased by BMS, has taken several years to get activated. It's just about to be activated. But it's weekly sub-Q Velcade and a more potent oral, instead of an IMiD, we call it a CELMoD. Interestingly, one of the first CAR T trials in myeloma is being done in transplant ineligible patients. And several centers in Canada are doing this. I'll talk a bit more about it later. But patients get RVD and then are randomized to CAR T, or more RVD, and then R maintenance. And we have entered several patients into this trial, and it represents really moving this new technology up front in a population of need. So I'm going to take a deep breath. My goal is, I hope this makes sense. This is tremendously, as I've said, shifting landscape, but I hope you can see where we've been, what some of the new trials are showing internationally, and what we're trying to do to stay abreast for our patients. So I'm going to move on from first-line therapy to an issue that is quite important, is as we've made some initial strides in first-line treatment, we want to be sure our second and third-line treatments continue to provide, hopefully, years of control before going on to the next line. So, right now, there are two practical groups of patients in their first occurrence. Those who progress on lenalidomide, like maintenance for stem cell transplants, or on Revlimid and Dex, or Revlimid Velcade Dex type treatment. And there are a whole bunch of phase 3 trials that lump patients progressing after 1 to 3 prior regimens. The problem is the results of most of these contain a minority of patients progressing on Len, because Len first line came in to the majority of patients after these trials started, and they take years to read out. As I've said, we are one of the few countries with public funding for Len until progression. Len was always meant to be suppressive, not given for a fixed duration. That's just the way it works. It's not like high-dose melphalan. You bomb the disease out and you go away. And then there was some discussion initially that if one progresses on lenalidomide doses of 5 or 10 milligrams a day versus 25 milligrams a day, are they really refractory? But I think in a practical sense, when the disease recurs in someone on lenalidomide, kind of any dose seems to be a warning sign. Now, sometimes you can increase the dose, get away with it for a while, add some dexamethasone and control the disease for a number of months. Some of you may have experienced that. That's not an unhelpful tool. I will tell you, we wrote up our experience of that in a CMRG database paper, and the American reviewers of the paper actually were appalled that we didn't switch everyone to triplet IV treatment when they progressed on lenalidomide maintenance rather than tweak it. They were horrified. And it's like, well, this is our data, but again, I'm not trying to diss my colleagues in another country, but I think we do have to appreciate when there's speakers and great deal of data and interesting data coming out of the US, that they have a completely different philosophy, increasingly divergent philosophy of treating patients. I'm not saying one is right or wrong, but trying to look at our data to support what we do continually. Because if we're not meeting certain benchmarks and helping patients, we need to change and do more what is done in the US rather than Europe. So I will say, having gotten information on how to treat first relapse for those progressing on lenalidomide, we're now going to have daratumumab with transplant ineligible patients. So our first relapse patients will be progressing on lenalidomide and daratumumab because they're both given continuously. And we're very mindful of trying to come up with the next line of therapy. I mean, we do have other drugs, other combos for sure, but we need to be mindful. We'll be using the database to see what do you get with that? What does the next line have, and what do we need to do to make it better? So I've shown here, the perplexing situation. First relapse is our patient not progressing on lenalidomide, and we can use lenalidomide. We're going to use daratumumab RD, the best second-line treatment ever reported, with a median progression-free survival of, 4 years. That's excellent. If the patient is progressing on lenalidomide, what we have had funded and we're appreciative of is bortezomib dex. The problem has been this trial that led to this was designed in Europe. They give Velcade twice weekly, they get peripheral neuropathy, and they only give 8 cycles, and then they stop it. And these are the other agents, and you'll notice in this group, a very important group, the alternative regimens have been Health Canada approved, but they're, I don't think, anywhere near being publicly funded. If patients have private insurance, they can often get these regimens, which is wonderful, but that leaves behind those that don't. And right now, we really don't have compassionate programs for any of the monoclonal antibodies. Now, I'll say a word about second transplants. We do have data from the prior era that doing a second transplant, if someone has had a benefit of at least 2 years, will give a reasonable second progression-free survival. And it may be better if you can add some sort of maintenance. If patients have progressed on lenalidomide after their first transplant, we've generally used ixazomib, a sort of oral Velcade, which is readily available compassionate, which is a gift from pharma, because they have no public funding, and some insurance companies will pay. But what about patients who've had lenalidomide and progressed? Is it worth doing a second transplant? And Sahar Khan from our fellowship program, who's now practicing in Windsor, has done a very nice analysis of the role of second transplant in the modern era. And it's been submitted for publication. But what she found is if you take all comers here, the progression-free survival after a progressing on lenalidomide maintenance is a little over a year. Now, that's not that long, but if you're trying to piece together different treatments, and the only timing you can do a second transplant is first relapse, it doesn't work well further down, is getting a year before you go on to the other treatments worthwhile. And her paper did some exploratory analysis that if the remission here had lasted 3 years, then it looked like it was definitely worth offering and getting around a median of 2 years after a second transplant. Now, again, these are medians. We have people that are 5 years after a second transplant, but at least gives us some updated information and shows the importance of auditing your real world data, because we have to be able to inform our patients to decide what to do more than the doc saying, I think this or I think that. You know, we need some evidence in this confusing field. So, sorry, I've lost my button. Now, we have done real world data, and it's published now, that shows that DARA-VD in the trials, the pivotal trials as second line treatment gave over 2 years median PFS, but they didn't have many patients progressing on len maintenance. And when we looked at our data, we got what we would expect. It was just under a year, which shows the challenge when people progress on one of the best drugs we've had. So a year isn't bad, and there are people that go longer, but this really provides evidence that this is a group of need for second line treatment. We've also looked at KD, which is another option in relapse patients. I could put it here or here, and actually I should put it here. If you're progressing on lenalidomide and get just carfilzomib dex, the median progression-free survival is 8 months. So, you know, we have work to do. Now, what have we been doing to improve on these gaps identified by our myeloma database in first relapse? One is to make KD better, if that's the choice. And our first trial for CMRG, we had to hire CCTG to run the trial because we didn't have our central office up and running, and it just added oral cyclophosphamide, and it improved the median progression-free survival to over 1.5 years in all first relapse patients, and doubled what we had in patients progressing on lenalidomide. And this is not just second line. I don't have the breakdown for progressing on len maintenance precisely, but you get the point. It really helped adding a simple oral agent, and some provinces fund this. This is not a phase 3 trial. This is not like what CADIF likes to fund. How can we improve on DARA-VD? So many of us have moved to, after the 8 cycles that the province pays for, continuing either bortezomib compassionately, it's easier to get because it's off patent, or free ixazomib beyond the fixed number of cycles, because we have seen people whose numbers start going up once they finish their 8 cycles of bortezomib. And as I've said, the reason for stopping it came from sort of the European mindset. And since we use weekly bortezomib, we don't have to stop at 8 cycles because we don't see the same degree of neuropathy. So again, once we have more data, we will look at this through our database, because I firmly believe you can't do these things if you don't at some point see if it worked or not. The outcomes are too important to not audit. Now, there are trials in this setting. The first one we've had is the Algonquin trial, which adds the monoclonal antibody with a warhead, belamaf, to pomalidomide and dex, which some patients could get after one prior line in some provinces. And we have a number of new studies under discussion. Now, we do have 2 industry trials coming up, which I think will help this earlier relapse. One is Majestic, which takes the BITE teclistamab with pomalidomide and dex versus DARA pomalidomide and dex, or POM Velcade dex. These are not funded regimens. And you'll notice that pomalidomide is now being moved second line, which has been which has not been a uniformly available through insurance or public funding. So we're moving pomalidomide up as second line. There's also a good Sanofi study coming up that this trial's open at PMH and I think some other centers. There's a trial of isatuximab IV PomDex, which, as you know, has never been funded third line like we've been trying to get for 2 years. But it compares it to this regimen with subcutaneous isatuximab. So I think these are really important trials to get to our patients in first relapse, not waiting till end of the line. Just talking about some of the newer agents as we move further down the sequence of options for patients with subsequent relapse. The antibody drug conjugate we have is belamaf. It is available through a compassionate program, actually a special access program through Health Canada. And before that, and now the Algonquin trial run through CMRG really has tried to fill an important gap between the availability of immunotherapy, since we didn't have DARA-PomDex or ISA-PomDex, and a number of patients have been treated. We have worked hard to try to find the sweet spot between the eye toxicity, which is reversible, but certainly involves dose delays, and balancing that with efficacy. It's not a perfect drug, but it has, I think, helped a number of people keep the disease in check till we have other treatments available. There's also a BMS conjugated antibody trial available at Princess Margaret in some centers that does not have eye toxicity, but it does carry the toxicity of the warhead. And we're trying to look at other trials for CMRG for this space. Now, I've kind of gotten the cart ahead of the horse a little bit, but if we're moving on to third line treatment, traditionally, it's been based on pomalidomide and carfilzomib or carfilzomib backbones. And this is where we have really pushed back with a CADIT, that you can't say patients can have one or the other. That's ridiculous. Now, I won't go into great detail. This is a busy chart, but it shows, I've shown you a little bit about what KD and KCD will do. But pomalidomide in third line or greater therapy, you can see that if you give it with cyclophosphamide or isatuximab, you get a response rate around 60%, and you get a bit less than a year median PFS. Now, it's very variable. but this is sort of our benchmarking, and again, points to where we need to go. So this is where we are looking at CAR T cell therapy and BiTEs to offer better therapy after patients have been exposed or progressed through Velcade, lenalidomide, and a CD38 antibody at different time points. Now, I think most people here are aware of the CAR T cell therapy. This is not an advanced disease, but the slide shows what the trial I just talked about, a newly diagnosed transplant ineligible patient. But the procedure is the same. There's apheresis. You spin off the T cells, not the stem cells, to grow back the marrow. In advanced disease, you're giving some sort of bridging therapy. I'll say off the bat, a challenge in someone who's had multiple lines of disease treatment and is progressing, and you're waiting that month for the cells to be processed. The bridging is usually not very effective, and it's a race against time. This is an important hurdle, and it's why moving CAR T cells up where the disease is not as aggressive will be an important move. When the T cells are ready and been re-engineered to recognize an antigen such as BCMA or another, the patient receives high-dose chemo, mainly to provide room and advantage for these expanded re-engineered CAR T cells, and then they're given to the patient. The first trial that looked at this in patients who had had a median of 6 lines of treatment was the ide-cel KarMMa trial. And I think this showed proof of principle that this strategy could be effective. The benefit was 8 months in all patients. And for the third of patients who had a complete remission, their duration of remission was becoming even more meaningful. And this was proof of principle. The concern among, in addition to the real challenge of getting people through bridging that didn't work, with this type of approach, we certainly had people that would get their CAR T cells sent off. Bridging did not work. And by the time it was for the lymphodepletion treatment and to give the cells back, the patient was way too sick, in kidney failure, and the whole process had to be aborted, which is a very tragic situation. So there have been a number, the CAR T cells with this platform tend to fizzle out. They don't last. But it did show proof of principle. And now there are many ways to improve the outcome. One is to treat the CAR T cells treat the patient to enhance the targeting ability of BCMA to target other antigens than BCMA, or target 2 antigens, and of course to use early in the disease course. The other challenges is cytokine release syndrome is fairly common with these regimens, and neurotoxicity is less common than with lymphoma CAR T, but is also, in my mind, very important to monitor long-term consequences of neurologic side effects that do resolve, but it will be very important to make sure cognitive ability, et cetera, those more subtle functionings are not compromised in the long term. Now, we have a new platform, the Cartitude, and cilta-cel is changing, I think, a lot of stakeholders' opinion of CAR T cells in advanced myeloma. And this is results from ASH, and those who had a complete remission, and the complete remission rates were very high with this platform. But even in all, the 2-year progression-free survival was quite good. So this looks very promising in the advanced population. And I've already listed the challenges with CAR T-cell therapy. And I did not show under here prolonged immune suppression. So as long as the CAR T cells are around, they're suppressing all antibody function. So many patients need monthly intravenous gamma globulin, very careful attention to infection. Again, these are manageable, but we have a learning curve to keep people safe in the long term. Now, the bites are an alternative. I've already shown you there's your monoclonal antibody recognizing a marker on the plasma cells versus a killer T cells. You bring them together. You can give these off the shelf. You can give them quickly. You can give them over and over again. Now they're being given subcutaneously. They have a similar side effect profile, but it's typically milder. We don't really see neurotoxicity. We do see fever, chills with the first dose, and we're having step-up doses. The hope is this will be able to all be given outpatient. Now the step-up doses may require brief hospitalization. The cytokine release syndrome is usually very unpleasant. I mean, having a temp of 39 and the shivers is unpleasant, particularly when we can't really give more than Tylenol for it, but it does pass. It's a consequence of the war here, and the smoke and the fire is these cells kill this. But ways to make that less unpleasant and do it all as an outpatient are underway. And as I've said, we have a variety of bites made by different pharma companies that target different antigens, and the race is on from pharma. I can't even list the number of trials with teclistamab, talquetamab, these other drugs that are underway by pharma. We really like the idea of using bite 1, then bite 2, bite 3, and then there are combinations underway of these bites, and particularly daratumumab, because teclistamide and talquetamab are made by Janssen, who makes Dara. Now, I apologize for this slide, but part of this presentation was to talk about updates at ASH, and these are the different bites that I just showed. And I'm often asked in clinic, well, what's the best bite? And this is to make the point that we have numbers of patients in these trials, you know, are very low, not much more than 150 in the most mature trials. And here, 55. Median lines of therapy is generally 5, 6. So it's the same group as the CAR T in many ways. But if you stand back and look, the overall response rate is somewhere between 50 and 70%. You can't tell dramatic differences. And again, these patients have different characteristics. Follow-up is very short. So we really have response rate, but they're all active after multiple lines of treatment. If you look at duration of response, not available, not yet reached, but the follow-up, 7 months, 14 months, 10 months. Progression-free survival, we don't have. Only for the first teclistamab trial, and it's the 9-month follow-up. Almost 60% of patients are still in remission. That's what we have. CRS is common, but it's rarely advanced with low blood pressure or other problems. And the neurotoxicity severe is very, very low. So there's where we are. At Princess Margaret, we're doing trials with teclistamab, talquetamab, and Dara, and I can say we put almost 20 patients on since last summer, and very few have come off trial. since that time. So I'm going to close because this is a long talk, and I don't mean to flood, but I want to mention again the cell mods. This is the new and improved lenalidomide and pomalidomide. CC480 is an amazing drug, and we've seen it work when 2 bites have failed, and it shouldn't be forgotten. And again, we've really pushed BMS Celgene, that whereas there's intense excitement about CAR T cells and bites, and that will be particularly attractive to the US oncology scene, don't forget that Canada loves oral drugs. We don't need to have patients coming in for long IV infusions for ages. Our system does not depend on that. So we are advocating and knocking at their door continually and coming up with ideas, and we do have the iberdomide trial, but we really want to integrate this. It's been slow. But anyway, that's probably another story. Selinexor is another combination. There are many trials in Canada. They have a very generous special access program from Health Canada. Many of you are aware that this is a drug that has a lot of GI side effects. There are mitigating strategies. It can be very helpful to suppress the disease as a bridge to something else. And it works by suppressing the myeloma. People may not have a complete remission, but the myeloma load goes down. You have to titrate it with the blood counts. But this and belamaf have been helpful for our patients who don't qualify for a trial, unfortunately, due to rigid eligibility criteria. Or another problem we're seeing that we never had before is we may have these trials, but we're assigned a spot on a trial. And if we don't have a patient to treat right away, the sponsor says, okay, no problem. We're going to give this spot to Mayo Clinic. And that's a new way of doing trials. Some of you may be aware, it's getting better as these trials are moving to phase 3, where you can put as many people on as you can. But we've had to redesign our research program that if someone needs a bite or a cell mod, we have a big grid about what they're eligible for based on platelets and measurable disease. And we have to measure or time that with when a spot's going to come up for teclistamab or talquetamab or selvostamab or a CELMOD. So patients don't get their choice, neither do we, of which trial. But all the trials we've selected for this space are good trials. And I hope I've tried to illustrate that it's not necessarily a loss which trial over another, because we can't predict yet who will respond to what bite or whatever, but it's a completely new way of doing clinical trials that reflects the intense competition for drug companies to come out with a bite and get it on the market. They don't want to wait a week or two till a patient becomes eligible. They'll just give the spot to another center, and we may have to wait 2-3 weeks. And our patient can't wait that long. So the goal is to have as many trials, good trials, so that whatever we have available is good for patients. So I've spent a lot of time going over a great deal of information, and I hope it makes sense. That's my goal, and I hope you understand our deep commitment to getting drugs to patients. That is the name of the game. It's not hitting a target. It's not publishing papers, it's getting drugs to patients. And I've shown here our CMRG network. We run with a fast crowd in competing for trials. We're competing with countries that have well-oiled machines. The European countries are experts at doing 500 patient trials at low cost. Their healthcare system pays for research nurses and coordinators. Canada's doesn't. We have to ask for money from the sponsors to pay for all that. But we do have an advantage that the European countries don't as a bargaining chip. In Europe, if a country says, okay, we wanted to do a trial with, let's say, Velcade and pomalidomide, the structure is, let's say, Celgene BMS is designing the trial and will provide the pomalidomide. Celgene also has to pay for the Velcade for everyone. In Canada, the one of the advantages we have is we are allowed to use our publicly funded drugs like Dara-VD from the public purse and add something to it, so the sponsor only has to pay or provide that one drug. So they don't have to pay for the pomalidomide if the healthcare system pays for it. So that's one of the few cards we have in terms of not being considered too expensive. The other card we have is we have a good network. We do good work. We have wonderful patients willing to sacrifice driving and the many visits to be on a trial. We have patients that aren't hammered like they are in the US before they're given to a trial. We can get people when they need it, second line, third line, because we have excellent relations with our community docs who don't need to hang on to patients for revenue. They send them very early. And in some provinces, it's one or two centers that centralize all this. And I think we do good research, and we are getting a reputation that pharma can come to us, we'll do a good job, we'll do it fast. But, we're competing against Mayo, and, UK has a great group, the Dutch have a great group, the Germans, the Italians, the Spaniards, and we're just new on the scene. We've only been in existence 6 years. So, we're really scrambling to keep up to get drugs to our patients. So I thank all of you for coming, the family members and caregivers, Myeloma Canada for doing a tremendous job at the grassroots level, the Bloom Chair, which has really provided seed money and really supports the salaries of our database still, and gratitude to all our supporters. So I'll close here, and I can't look at the chat.
Okay, Dr. Reece, wow, what a fabulous presentation, very comprehensive. And as you described, you and your teams are doing very well at getting drugs to patients. You do very well at patient care, at collaborating across the country, and developing a world-class research network. So thank you so very much for that. Now, we do have a little time for questions. So Johnson, why don't you lead us through, particularly
Sure.
the questions there that might be appropriate for Dr. Reece.
Sure. There were a couple that I know will be really quick to answer, that were just a couple of clarification points. There was one that somewhere in the presentation you mentioned, and the name of a test that can be used to detect early pneumonia rather than a chest x-ray. Can you just repeat the name of that test? Someone had asked about that.
Yes, and the chest x-ray is a classic way to look at pneumonia, but it's a two-dimensional picture. A CT scan of the chest is three-dimensional, and there's something called a low dose. That means a very low dose of radiation. It doesn't need any dye. and it gives a three-dimensional picture of the lungs and picks up an area of pneumonia much, much earlier than it shows up on X-ray. And it may show a pneumonia when you don't see it on X-ray. Major centers have been doing this for immunosuppressed patients like allogeneic stem cell or bone marrow transplant, organ transplants for years. And we have data back in my days from Vancouver that chest CT scans, this is not a big fancy one. It takes just a few minutes and you can slot it in. And, you know, if you do a chest x-ray and you see something, fine. If you don't, then you really need to know if your patient needs something strong. We end up doing a chest CT anyway. So we encourage centers and emergency rooms to, if you can't sort out what's going on in the right setting, please just do a low-dose chest CT scan. You will see so much more in a short time. And I think the major centers are coming around to that, but it's getting it out to the emergency room docs.
Great, thank you. And very early in your presentation, you discussed various doses of lenalidomide, some low dose versus high dose. What is considered a high dose of lenalidomide? Just so we kind of have that reference.
Yeah, it's tricky. The trials were done for active treatment with 25 milligrams, 3 weeks on, 1 week off, 3 weeks on, one. And that's with the concept of maximally tolerated dose. And I think when you sit and talk in panels of doctors in Canada, you know, we know that if someone's older, you know, you can give 25 milligrams, but then you're going to get potentially side effects. They'll go away, but you can get taste changes, diarrhea, fatigue, your counts can go down. You can often tweak the dose and go down, but your patient has then gone through a period of unpleasantness, isn't too keen on taking a drug indefinitely. And many individuals respond to much lower doses in the real world. I have very frail patients who are starting myeloma treatment, and if they are frail, I'll put them on 5 milligrams of lenalidomide, and many respond. I don't need to go up. So I don't think with these non-chemo drugs, we know how to optimally dose them. So you know, and people's myeloma responds differently. You know, the dose response curve is not clear cut. You know, I have people that show their numbers go up on lenalidomide maintenance, 5 milligrams. You put them on 10 or 15 and they get better. And some people don't. So it's a messy, messy area. But the dose that was first put forth for maintenance post-transplant was 10 milligrams a day without a break, which makes no sense to me because the therapeutic gives a week off every month to let your blood counts recover. Why are we giving it every day? You said short answers. We did a nice study at PMH correlating with quality of life that said it was 130 patients. We looked at in our clinic the average starting dose of lenalidomide maintenance in our patients was actually 8 milligrams. When you take all these patients, not 10. If you looked 3 years later, the average daily dose was 6 milligrams. We never went up to 15 like the old trials. And our median progression-free survival was very close in the real world to what you see in the trials that push the dose. So, we have some quality of life data. It was very acceptable. So why are we pushing people to 10 a day? We have other database data from the trial I showed you with that showed the 58-month median progression-free survival, the Alberta group did a subset of their patients getting 3 out of 4 weeks maintenance or 4 out of 4 weeks maintenance. They had the same outcome. So I get so frustrated. I think it's easy to over-treat patients, and you always have to balance quality of life. So what is a full dose? I don't rightly know, but hopefully that gives you a perspective. I think there's still the mindset, even with the bites, to give the maximally tolerated dose, after which the wheels come off the cart, and then you just go down one dose level. Yeah, and that mentality has been fixed in pharma since the first chemo drug. And I think in our Canadian world, we don't need to do that for certain drugs and for certain patients. So this you can tell is a thorn in my side, because as people live longer, they have to live. You know, I mean, we continually have to work on mitigation strategies so people can live, not just treat a number or hit a target.
Great. Thank you. Okay, I'm going to go down the list of questions. Excuse me. And the next one is, when would people sort of recommend a tandem transplant? Was one of the ones that came up as well.
That's an excellent question, and it is controversial. We are now, I showed you some early data from an ASH poster that Peter Duggan in Alberta did in 2020. And we're now working through a deeper statistical analysis. And it's real world data of 1 versus 2 transplants in high risk disease. I'll start out by saying it drives me, another thorn in my side is we're not accurately determining high risk disease. You know, the fish chromosomes are better than nothing, but Mr. Bloom from the Bloom chair has very publicly said he had deletion P, 17P, and in an era before daratumumab, lived 9 years. Now that's not high risk disease. But we're all thinking, oh my gosh, you have high risk disease. It's a minority of patients with these chromosomes, these fish, that are really high risk. Conversely, there are people that we think are standard risk and the disease comes back in a year or 2. We are not serving or identifying people well. So again, we're trying to get better risk identification. And what we're doing at Princess Margaret with philanthropy is doing our 38 gene panel in addition to fish for newly diagnosed patients. We've just got some funding to add some other panels that are from other centers that we're working on deciding, and MRD, to learn more about tandem transplants. But our own data from PMH and nationally suggests that tandem transplants are really important if you don't give maintenance. If you give maintenance, they seem less important. The maintenance helps so much in prolonging the disease control. Now, you may pay the price. You've seen the challenge of relapsing on that. But the 2 analyses that try to really look at it, we did one at PMH of 1 versus 2 transplants versus none in high risk. And we found that if you had, most had maintenance, the tandems did much better. But people who are healthy enough to go through tandems may just be destined to do better anyway. And by the ability to go through it and being strong and healthy and fit, maybe we're just selecting the patients that are going to do best anyway with tandems. That's the same challenge with the other trial that suggests the stamina trial, which was supposed to answer this question. Induction, usually RVD, versus 1 transplant maintenance, 2 transplant maintenance, or RVD consolidation and maintenance. And the only group they found that did the best for high risk were those that had tandems, but they actually got it. They weren't assigned to the group, they got it, maybe healthier patients, and then got maintenance. And that was the best group. And then there's one European trial that shows that tandems with maintenance is better in high risk. So it's messy. I go back to, we need to know who's really high risk. But also, when I first came to PMH, there was a time that before we had the good drugs, anyone who didn't achieve a 90% reduction in their monoclonal protein and were younger had a tandem transplant. So it's a blunt instrument approach, but it's not a fringe approach.
Great, thank you. Now, actually, that ties into one of the other questions that came through as you talked about clinical trials. There was a question that said, do you inform community hospitals and hematologists of all the clinical trials you're offering, or does one have to be under the care of PMH to be considered? So, because I know that some of our members are from, from our suburbs and the GTA in general or whatever, and so are probably wondering about access to some of those trials as well.
Sure. No, we send out a list every month to a very large group of community physicians and pharmacists. Now, it lists all the trials which are accruing, the infamous eligibility criteria, because some require platelets of 50, some require platelets of 75. That's often a limiting factor. 2 lines of treatment, they may need to have what drives us nuts, measurable disease, which means their M spike has to be so high so you can really monitor. They may exclude light chain only. And we send them out every month. I think the busy community docs, they just send us a referral, and that's just fine. And we triage, and we now have set up, when we get a referral, we run it through that system with the basic characteristics and say, what trial do we have? We actually hired a person to do this. We could not keep track the old way and say, okay, we think this patient could have X, Y, or Z. Then we have to look and say, do we have a spot in the next month, 2 months, 3 months? That will get better as we have phase 3 trials, but those are randomized. But we widely take email questions from busy community docs. We have our Myeloma Day where we distribute all our trials. I'm actually meeting virtually with a group in Oshawa just to talk about what clinical trials we have. And all these are good young docs. We send them this list every year. But, with the community docs that are looking after all blood diseases, it's overwhelming, particularly during COVID. There's just, but we distribute that widely every month.
Excellent.
Dr.
Thank
Reece,
you.
if I may mention, that list is also posted on the Myeloma Canada website under research. So patients can see that. And if there's something that they're interested in, they can discuss that with their doctors.
Yeah, we did also go through a period, as you know, with COVID, that we could either not treat patients on trials. I mean, one of the big impacts, COVID's been awful, but so many staff have been sick. If you don't have the nurses and the team to look after patients, you simply can't do it. We had a time with the last wave in January that all our chemotherapy nurses at PMH were down 46%, and all new chemotherapy treatments for solid tumor patients to start was automatically delayed 4 weeks. there was no staff to give chemo. And I think that's what people don't appreciate, the impact. When your staff is sick, you don't have people to give the drugs. We were so bad that people would have a CT or an MRI booked and they'd get called in the morning and said, look, the tech is sick. I mean, they're not fatally ill, but they're off for so many days. I mean, in clinic, the fellows, kids get sick and then they're off for 5-10 days, who knows? So the impact on cancer treatment has been really profound. And we were not able to activate any or enter patients into any trial that had a control arm that was standard. You could just get that treatment anyway. You can't get the goodie. We don't have staff and all the precautions. So, the consequences of COVID have been profound on research. And the CAR-Ts were held. We held transplants with the first couple of waves. So, we're slowly picking up, but it has been profound on what we're allowed to do. And during COVID, we were only allowed to operate 50% of our trials that were open. We could, it's that sort of thing. It's better now. But the last 2 years has been profound impact on our ability to treat the average individual and to treat clinical trials.
Mm-hmm.
But it's better.
Good to hear it's getting better. Thank you. Okay, now we have, there's a question here that might have been answered through the presentation. So if you just remind me if you did speak to it. Okay. This one was about, and we do have sort of quite a few more questions yet. This says, what does current data say about DARA plus lenalidomide maintenance? And what's the expectation for ISA and Len maintenance? I feel like that was part of the presentation.
No, that was
maybe not.
The slide that showed the updated trials from ASH last year that gave DARA and Revlimid for 2 or 3 years, or ISA. The German trial uses ISA and Revlimid. And all we have now is 2 or 3 year follow-up when most patients aren't experiencing relapse anyway. But a high proportion are staying in remission, and crossing fingers. I didn't really emphasize a high needs group that isn't very common, but is really problematic, is those patients that relapse in the first 2 years. And it looks like if the CR rates are 88%, I'm sorry, the progression-free survival is 88, almost 90% at 2 years, maybe those early relapse patients, that 20%, is going down to 10%, chipping away. But I think because a stem cell transplant's 3 parts, they're each important, but none of them has to do all the work. So you have your induction, you have your high-dose melphalan, which does something really harsh on the myeloma that nothing else does. You give a high dose of melphalan in the older era when there was nothing else but Dex and vincristine and maybe thalidomide towards the end of that era. You still got 18 months with median of disease control. Nothing else does that with one-time pump. And then you have your maintenance. And if you look right now and you ask me, and many people won't agree, that's fine. The data has to play itself out. That's why we do the trials. Since most people respond somewhat to induction, no matter what it is, they get their transplant, very rarely progress very early after transplant. If you ask me where I wanted to put DARA or ISA, I'd put it at maintenance. That's it, because that's where we see the number, we mop up and I showed you the slide of just what Revlimid maintenance did in Canada. It, without changing much else, it dramatically improved the progression-free survival. So if we can make that go 8 years, 7 years, you know, it's nice to offer it in induction and other, but I think the data for immune therapy in maintenance is incredibly promising. That's why, in my mind, that's one of the highest priority groups to help, as well as, of course, the more advanced disease settings.
Great, thank you. There's one question here that says, how do Zometa treatments fit into our overall myeloma care? I know many of us are on Zometa or various similar kinds of drugs. Where does that fit, and how does that fit with all of our overall care?
I think it's important. I think as we've gotten better at controlling the myeloma, that's the best way to prevent bone damage, to control the disease. And it's a simplified biologic interpretation, but when people are in remission, they're generally not breaking down bone. So I think the Zometa is a class of drugs that's used for osteoporosis of all causes, keeping in mind that the mechanism of thin bones for myeloma and age-related postmenopausal osteoporosis are very different. But after myeloma is in remission, one doesn't easily rebuild bone. And I think the Zometa can help. I am, being old has very few advantages, but when I first came to Princess Margaret, the trials that were being done were Zometa, pamidronate. And the drugs were given 2 years or 21 months in advanced disease and improved bone events. But then no one figured out what's the optimal duration. And then people were given monthly Zometa for 5, 6, 7, 8 years. But bone is dynamic. We have to build and sculpt, because where we carry our weight changes. And what we saw was one of the areas with the most pressure is our jaw. And you have to remodel as your teeth shift and this and that. And if you build bone, and you can't remodel, what we found is after years, the center of the bone just dies. It can't remodel. And then you get osteonecrosis of the jaw, which is really nasty. And then we started seeing stress fractures in the upper femurs, because that's where we carry all our weight. We sometimes see tiny fractures of the feet because those bones were not allowed to remodel. So we learned that when it was being given monthly. So I think in the absence of a good marker of bone breakdown, judicious use of Zometa to counteract bone damage is really important. But when I am a minimalist, again, because of the toxicity, and I think the data suggests a year or two, and often, unless someone has really terrible compression fractures, every 3 months looks quite good. And then again, my experience in the US practicing oncology is hematologists want to give it every month because that's income forever. And I'll just say it. And it's not, because the data hasn't looked, the studies haven't defined how little you need. Why would pharma do that?
Interesting points. No, I appreciate that. That's great.
No, I think you always have to take with a grain of salt. All this was based on 21 months of treatment back when we had crummy drugs. It's a great drug. We're not seeing people horrendously bent in two with compression fractures, which was horrible. So it's important. but it's an adjunct. And keep in mind, when someone has plain old osteoporosis, their doses of Omega is once a year. It lasts forever. Great. In the bones. So anyway, I don't mean to be a nihilist, but it's learning how to use these judiciously to help people with minimal side effects.
That's excellent information. Thank you. Another question that we have had is regarding the combination of Kyprolis, I never remember if I say these right, Sarclisa and Dex. Is there information available about that kind of combination?
Yes, I think the very promising regimens for first relapse on Revlimid are carfilzomib, Dex, and carfilzomib or Kyprolis, Dex. They're approved by Health Canada. They're being reviewed by CADITH. I'm not sure funding is imminent at all. People can get it through insurance. And what the data suggests, it's very preliminary. I think we only have it for the Dara Kyprolis Dex, is that if someone is progressing on lenalidomide and gets this regimen, the progression-free survival is 28 months, which is really compares favorably to Dara VD. Although keep in mind, we stopped the third agent 8 months, by the way. So I think that is a very good regimen. And we do have people getting it first relapse. The competitor is through trials. Dara or Pomdex. It hasn't been funded at all third line, and now the studies are going to be giving it second line. So you're taking a monoclonal antibody and either POM or carfilzomib. Carfilzomib is a very potent drug. And I think particularly for people with more aggressive disease or people whose goals of care is to treat very aggressively, that the carfilzomib antibody Dex is an attractive regimen. What I consider in recommendations are practical things. I mean, I'm always embarrassed and think it's inappropriate for me to say what I think an individual with myeloma is feeling. But ideally, when someone is on Revlimid maintenance post-transplant and the side effects are manageable, that's the least drug they'll be on during their sequential treatments. And that's when, if that people can try to go back to work or get back into their life. And the Kyprolis combinations are still 6 IV infusions a week, plus the monoclonal antibody. And I think one has to have a good discussion with their patient. That's a lot of treatment indefinitely. Now, Dara eventually is once a month. It will be sub-Q. Isatuximab is every 2 weeks. So you're taking someone who's hopefully gotten back into, some sort of relatively good state. And then all of a sudden they're spending all that time. And we are going to be doing a trial with San Francisco that will give weekly carfilzomib, Kyprolis, and isatuximab, which is more palatable, but it's like night and day in terms of what I think would be the patient experience. Carfilzomib is an excellent drug. There's a low risk of cardiac toxicity, which we can't predict. It's not common, but it is something, every drug has a special consideration. Peripheral neuropathy, diarrhea, this or that, blood clots. And for carfilzomib, it's being aware of a low risk of cardiac. Pomalidomide combinations seem a little bit less potent with a monoclonal antibody, but in some, it's all oral. When you get past the loading doses, you're kind of taking Pomdex plus an infusion that will eventually be sub-Q for DARA. So potentially the quality of life is different. Of course, with all these monoclonal antibodies, you need to worry about infection. We've had to learn how to counteract that. And to me, it's like, which regimen is going to be right for which patient's second line. So I'm all for getting all of these. Push. These are just my personal views. And I think other clinicians may have other biases to fit with their patients, but having these choices are wonderful. And the Kyprolis combinations are right now, second line based on that one study with follow-up, look very promising. I'm not giving short answers. Sorry.
Okay. We do have a couple. We have a few more yet. There was one here that was about Revlimid that carries we know Revlimid carries a risk of developing secondary cancers. How does daratumumab fit with that? Does it also carry the similar kind of risk?
Doesn't look like it. And the good news with Revlimid is Revlimid Dara-Dex, Dara-RD, frontline therapy for transplant ineligible, does not carry an increased risk over RD alone. And the risk of secondary malignancies is most concerning is if Revlimid's given close to high dose chemotherapy. We monitor it very carefully. It's not something to be at all brushed under the rug. Many are skin cancers. I wonder, when we've looked at our data in Canada, it's not an epidemic is the term I use. And I have not a lot of data at this point, but I wonder if we don't give the biggest doses of Revlimid and we give it 3 out of 4 weeks and give a break like you do, can we mitigate? Right now, our mitigation is being very attentive. And I think the other factor for maintenance, which is so helpful in prolonging remission, is the data from the meta-analysis of Revlimid maintenance is most of those cancers, not all, could be treated and cured. So, I'm very sensitive, I hope, to this. So the risk of dying from a second cancer is much less in that setting than dying of myeloma. Some people, and the question comes up, what if someone has had a common cancer like prostate cancer? Can you give Revlimid maintenance? So there are unknown issues, but the short answer is it doesn't look like DARA with Revlimid adds to that at all. It's being monitored, which is good news.
Great, thank you. There's a question about Ninlaro, which I know some of us are on, and maybe in combination with our Revlimid, regarding sort of the difference in dosages. So if for a patient who might have a few side effects on 3 milligrams, but suddenly has lots on 4, is there any study showing how much longer myeloma stays in remission on 4 compared to 3? So obviously we want to stay on the 4 if you can mitigate the side effects.
I think one would want to know what the side effects are. We found that often it's diarrhea that can be very impressive. And for several years now, I always give 8 milligrams of ondansetron before every oral dose. And that has pretty much anecdotally eliminated that problem. And it goes back, again, I talk too much, and being an old timer sometimes helps. When we first started using bortezomib and bortezomib IV, we saw diarrhea people on their way home from the chemo suite. It was terrible. And as we're building our computerized orders, our pharmacist wanted us to build in anti-nausea drugs into every regimen. And it was well intended. Well, people don't get nauseous from Velcade, they get diarrhea. So they insisted we put in an anti-nausea drug. So we put in all our automatic orders, we don't write them out anymore, 16 milligrams of ondansetron. And guess what? We still didn't see nausea, but the diarrhea on the way home stopped. And we don't see very often diarrhea with Velcade, and it goes down a bit with sub-Q, but it's still there. And so it works in almost everyone because we're using an anti-nausea drug that's very constipating and usually gets us into trouble. You know, when people get constipated, they may be as miserable as they are with diarrhea. Now, when Ninlero came, we forgot about that because Ninlero is not very nauseating. But when we first started building it in the computer, we didn't give any anti-nausea medicine. And we started seeing diarrhea again several years ago. And actually the point that a few people got dehydrated and needed IV fluids. So we built in as a hope, because Imodium, yeah, you know, you're after the fact, it doesn't work very well. We just picked out 8 milligrams, exploiting ondansetron for its constipating effect. And we don't see much diarrhea anymore. So
great to hear, as someone on Ninlero.
yeah, I would definitely try 8, 1 or 2 on. Well, I can't tell you what to do. Suggest to your physician, but it seems to have almost eliminated the problem. No pun intended.
Thank you. That one was not my question, but I really appreciate the answer.
But it's funny how you learn these things. And it's one of the advantages of having clinics with nobody except myeloma. You have to listen to what your patients tell you, and these sort of incidental things that seem to help.
Great. Well, we just have a couple more questions. One of them was about some of our preventative medications. Like many of us are on acyclovir against shingles, but what is levofloxacin and what is it used to treat?
Levofloxacin has been used on and off for many years in people undergoing chemotherapy that's going to make them neutropenic. Different centers may use it or another antibiotic during a stem cell transplant until someone becomes febrile and needs to go on IV antibiotics. And there was a study from the UK several years ago that I believe gave 4 months of levofloxacin in newly diagnosed patients and reported that it decreased the incidence of infections during that initial period, and there was not more C. difficile. I mean, I say with no desire to be, snarky, but there are no free rides in cancer medicine. You do something else has to be mitigated most of the time. But there wasn't more C. difficile from antibiotics. So extrapolating that to using DARA later on in treatment is a stretch, but we do see, the main special consideration with ESA and DARA is infection. And if someone's has active progressing myeloma, that's a setup for infection. We also have people we know seem to be prone to sinus and bronchitis or pneumonia. And so variably, we will offer those people at the beginning, particularly levofloxacin to prevent bacterial infections. We usually don't consider it continue it long term. The shingles is important. The vaccination, Shingrix, can be safely given in immunosuppressed patients. I'm all for it. I'm still afraid to stop acyclovir because shingles can be devastating. And twice daily acyclovir is so benign. The old days when we treated shingles with acyclovir, it was now I'm getting mixed up. It's I don't mean how many tablets 5 times a day. I mean, it's so much higher. We don't use it anymore too much. But, to take 2 tablets a day, viral resistance is extraordinarily rare. It's a very safe drug. At one point, they were going to make it over the counter for genital herpes, and that wasn't done. But I'm not simplifying the toxicity of any drug, but it is such an easy maneuver, and there are not a lot of breakthrough cases. Great. And PJP we know is important now, after kind of forgetting about it once we stopped using 4 days in a row of dexamethasone, but that has become important.
Well, that may very well connect then to this next question regarding the prophylactic sulfameth or trimeth DS for pneumonia and other infections. If that antibiotic creates severe gastrointestinal challenges and skin eruptions, is it absolutely necessary to add it to the DARA, Dex, and Rev regimen?
Yeah, that's a good question. The Septra, only when you're preventing pneumocystis pneumonia, it's really only 3 days a week it's needed. And now we're kind of down to 1 pill, sometimes 3 times a week. But yes, there are people, can be nauseating, particularly if you give it daily or twice daily. It can cause a skin rash. And it can't be used when the kidneys are really bad. So we shouldn't use it. We are putting those patients, we follow the guidelines that we do for other high-risk populations, which are allogeneic transplants. We used inhaled pentamidine. It's inhaled once a month. And it's not quite as effective as the sulfa drug, but it's pretty close. So rather than do nothing, we've learned it's not a huge incident, but it's almost completely preventable. And pneumocystis pneumonia is not pleasant, and it can be fatal. I mean, we're seeing, the trade-off with immune treatments is more infection. And having started out my career as an allogeneic stem cell transplanter, it is so reminiscent of the infections we saw back then. Shingles, pneumocystis, CMV. Is clearly being seen with new immune treatments. Now, it doesn't always make people sick. It usually doesn't cause pneumonia, but we are needing to be aware that can be in the differential of diarrhea in terms of enteritis. So it's history again, but there are strategies to prevent that. And again, I think we're learning about that. We're hopefully going to look at it more with our database and educate the community to meet the challenge.
Great, thank you. We just have a last couple questions. Hopefully, these are quick, easy ones to wrap up with. although this one I know we've talked about in our groups before, is there an upper age limit for a second stem cell transplant? And I know that has a lot of factors often that contribute to that consideration.
Yeah, I mean, we've gone back and forth in our age limit, and I don't think it's a secret. It's been resources. There are times when it's not happening as much in the last few years, but there were times our waiting list for a first transplant was totally unacceptable, and you got to treat people. So I think we will, again, if with appropriate counseling and screening for health, we'll do a second transplant up to about age 72. It's not a fixed age limit. It's physiologic age, because, the mantra is there are people 68 going on 90 and their patients 72 going on 58. So, the age limit has become much more relaxed. And I think it's whether that it really depends on the duration of first remission, and how hard or easy the first transplant was in the patient's experience. But we really try not to let age per se be the limiting factor. When people are much over age 72 or 73, the recovery period can be quite long with fatigue. I go back to when I practiced in the US, there was no age limit. And, I can remember transplanting lymphoma patients up to age 76, and they got through it, but now they get more high dose drugs, being totally fatigued for a year. So I think that's the kind of thing I worry about, not so much the age. It's the diminished quality of life. But for some people, the transplant, it's highly unpleasant, but it in the end, it was felt to be a good treatment for that person.
Excellent, thank you. We just have one last question that connects, I know, to the pandemic that we're battling and COVID-19, and we are hearing a lot about sort of an anti-COVID pill, or those other sorts of responses or supports that are out there. How would one, particularly with myeloma, go about getting that anti-COVID pill? From whom? What have you heard about that process?
I think the important thing is that the patient's doctor knows, their hematologist knows. It seems pretty uniform for patients that don't live in Toronto, but there is at UHN, a COVID clinic referral. As soon as we know, we send in that referral. It asks for all sorts of questions, and then this can be done with a rapid antigen test at home or a PCR. We then send a referral by email to the COVID clinic, and an ID person, specialist, will contact the patient, usually within a day or two. And until very recently, that infectious disease person, as long as it was within a week of diagnosis, would arrange for the patient to have intravenous sotrovimab. And that has been shown to decrease the risk of hospitalization or intubation. And I've had a number of patients work with that. And because you have a few days after the infection starts, even on the weekend, they get back pretty quickly. And the ID people, specialists, have been amazing taking these calls. Now that form has been modified to include potential treatment with the new oral drugs. It's a bit more complicated because, as you may know, the new, and I can't even say it, at least the first antiviral that's been available reportedly doesn't cause a lot of side effects when you take it, but interacts with a whole ton of drugs. So I filled this out on a couple of patients. You need to list absolutely every drug a person's on, everything, not just your prescription, but anything. It goes to a specialized, you get a list of potential interactions, or, there's a red, green, and yellow coding system for these drugs. Then it's checked by a specialized pharmacist, and then we can write the prescription, and an ID person is involved. And the two people I put this through were extremely medication adverse anyway, and we're on 1 million drugs, and we're mildly infected. We just did the sotrovimab and they did fine. So that's the mechanism. I think we'll learn more about it. And it's not that these drugs make people sick or that horrible things happen. It's just the interaction may make the levels of the other drugs go up or down. And
I noticed that. I looked at the list, I think, and blood thinners, for example, was one of the interactions. I was like, oh, I'm out. Okay.
Yeah. And then it becomes a question of risk benefit. And then there's a continual issue. Is sotrovimab going to work for the new variants? It seemed to be the only one, the therapeutic antibody against COVID. It seemed to work against the first Omicron, I guess, 1A. I don't know if it works against 2A, but we do. And we've referred patients who live in other cities, if they call us, to tell them to go to their center, and they seem to get the same option. So I think this COVID clinic concept has been spread across the province. So our patients should be able to get what they need. And we need the advice of the infectious disease experts, who have been amazing throughout this pandemic. I mean, calls, online risk, trying to advise government. I mean, these are real heroes in terms of trying to get these drugs, because there's certainly not extra staff trying to do this.
Dr. Reece, if I may just add a very brief question and comment, and then I think we should probably, think about bringing the meeting to a close. But I understand in the U.S. there's a new drug vaccine that's called Evusheld that's being used fairly significantly for myeloma patients. It's not approved yet here. Do you have any thoughts on that?
I don't yet. I mean, there's all these promising things coming out, as we're told we're going to have to live with COVID. So, I think we have some very good ID people that were involved in the scientific roundtable that was advising government and just got disbanded. So I go by what they say. So I wish I had more information, because I know people go to the US, but I don't know the data yet. Okay. I'm sure it will be, we'll get updates soon, and I don't know the status with Health Canada approval. Hopefully it will be available sooner rather than later.
Okay, thank you. Yeah, Jocelyn, was there anything else in the chat?
Nope, there's nothing else in the chat at the moment.
Okay, this has been fabulous. The question and answer, we've learned a tremendous amount there. Ideally, we had in mind opening the floor, basically, the audience, for any questions they might have. But, we're already getting fairly late in the day. You mentioned something about getting ready for dinner, Dr. Reece. So it's now 4:43. So I would suggest that we look towards bringing the meeting to a close, unless there's anything else in particular, Dr. Reece, that you would like to mention.
No, just a special thanks to everyone for taking the time to listen and being a wonderful group to try to bring new treatments to. And it has to be a two-way street and a grand collaboration to keep knocking on the doors that need to be open to bring better treatments into our country.
Okay, that's fabulous. Thanks very much. Well, we have Bob Bacaw here, who would like to say a few words of gratitude for you and the wonderful presentation. So, Bob, are you there?
Yes, I am. Thank you, Dave. One of the phrases that caught my attention this afternoon was an explosion of new treatments. And just want to take a very quick minute to tell, for the newer patients and caregivers on the call, I am in my 17th year. I have 3 transplants, and I'm coming up on 4 years since that 3rd transplant, and currently on Dara, Rev, and Dex, and Zometa, and doing well. And I guess my point is, 3 of those drugs were not even available when I was first diagnosed in 2006. So we have come a long way, and these are very, very encouraging times. And with that in mind, excuse me, occasionally you'll hear through Myeloma Canada or this patient support group and others that we need to send letters to our government officials, whether it be your local MPP in Ontario, because when these drugs come along, they need to be approved by Health Canada. Then it's to go to the provincial government. And being one member of several on this group today that have gone to Queen's Park twice to fight for pomalidomide and Dara successfully, I might add, it's very important. Research is very important to a myeloma patient. So when you do hear a request for letters to your local MPPs, they do work, and donations are quite appreciated as well. So, Dr. Reece, it was a tremendous, awesome presentation based on the number of questions and comments in the chat room. So I want to take a few minutes to thank you for the time that you've taken to organize your slides and your presentation. And also thank you for the time away from your family, and that includes your cats, by the way, and scheduling to be with us today. And with our deepest appreciation, we will make a modest donation to the Molly Bloom Chair on your behalf. And thank you so much for your time again.
Well, thank you. I think the sentiment that you've expressed and the donation mean all the world to us. My cats, I just have to lock out of the room because they like to get up on the computer where it's nice and warm and can be loved, but it's not the right time. They're not starved for love. But anyway, thank you so much. As I said, it's been a privilege to speak to all of you, and it's great to have an opportunity to let you know what's going on behind the scenes, and to try to beat this disease until we have a cure. And there's a huge group of people nationwide that are committed to this with vigor, and we will continue on. So thank you very much to Dave and you and Jocelyn and the rest of you. I wish you a great day, a great month, and great access to all these new treatments. So take care, everyone.